Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today we're plunging headfirst into the really high-stakes world of emergency surgery. It's a realm where every single decision can be, quite literally, a matter of life or death.
Absolutely. The pressure is immense.
It really is. And we're going to unpack an intervention that demands incredible precision, speed, and just this intimate understanding of human anatomy, the Hartmann's procedure.
A classic and crucial operation.
Exactly. This isn't just any operation. It's a key, often life-saving surgical intervention used mostly in emergencies. We're talking things like complicated diverticulitis or colorectal cancers that are blocking things up or have even perforated.
Or major trauma sometimes, too.
Right. Or severe traumatic injuries to the colon. Basically, it involves taking out the affected piece of the colon, creating an end colostomy stoma, and then carefully closing off the remaining rectal stump down below.
A three-part process, fundamentally.
Precisely. So we're framing this deep dive as a sort of surgeon's essential guide. We'll take you step by step through this critical operation, drawing insights directly from expert sources. Our goal, to break down each vital component, from the initial prep right through to post-op care.
To really get under the hood.
Yes, to understand the key elements and why that meticulous attention at every single stage is just so vital. I'm especially interested in exploring not just what happens, but the real why behind each careful step.
And what's truly fascinating here, especially I think for new surgeons listening, is that mastering these key components isn't just about memorizing a checklist.
No, definitely not.
It's about deeply understanding the why behind every action. And that depth of understanding is incredibly crucial for optimizing patient outcomes, particularly when you're facing these acute colorectal pathologies that often show up as life-threatening emergencies.
Right.
Knowing the why helps you anticipate complications, make those rapid decisions under pressure, and ultimately navigate the unexpected, which happens a lot in emergency surgery.
That's such a powerful point. So, okay, let's set the stage. Let's start with that first critical phase, preoperative preparation. Before a surgeon even thinks about making an incision, a really thorough patient evaluation is just non-negotiable.
Absolutely fundamental.
And our sources lay out very clear indications for Hartmann's, things like perforated diverticulitis with diffuse peritonitis that's, widespread infection in the belly.
Nasty stuff.
Definitely. Or obstructing or perforated colorectal cancer, trauma causing irreversible colorectal damage, ischemic colitis where the bowel tissue is actually dying.
Or even failed connections from previous surgery.
Exactly. Cases where a prior surgical connection and an anastomosis has just catastrophically failed. These are all really high-stakes situations where swift, definitive surgical action isn't just preferred, it's often the only way forward.
But this raises an important question. While those are clear indications, it's just as crucial to think about the relative contraindication.
Okay, like when you might hesitate.
Precisely. For instance, a patient might come in with severe hemodynamic instability. Their blood pressure is tanking, circulation is compromised.
Right.
In that case, you might need to prioritize damage control surgery first. Just get in, stop the leak or bleeding, control the contamination, get out, and stabilize them before attempting the full Hartmann's.
Kind of a staged approach.
Exactly. Or maybe they have severe comorbidities, advanced heart or lung disease, for example, that significantly hike up the surgical risk. These aren't absolute no-goes, but they demand really careful surgical judgment.
A tough balancing act.
It is. You have to weigh the extreme urgency against the patient's ability to actually withstand such a big, often long operation. It's a fine line.
Okay, so once that critical decision to proceed is made, the preoperative workup kicks into high gear, often happening right alongside resuscitation efforts.
Simultaneously, yeah.
This involves imaging, usually a CT scan of the abdomen and pelvis. And this isn't just to confirm the problem, but crucially, to see how far it's spread and spot any other complications.
See the whole picture.
Exactly. Then you've got the labs, CBC for infection or anemia, electrolytes for fluid balance, coagulation profile to check clotting.
And crucially, a blood cross-match.
Yes, perhaps most vital in an emergency, a blood cross-match, because you always have to be ready for significant blood loss in these situations.
Always.
And finally, resuscitation efforts are started right away. 4V fluids, broad-spectrum antibiotics, often combinations like piperacillin tazobactam, or maybe meropenem to cover all the potential bugs in a contaminated abdomen.
Good coverage.
And maybe an NG tube, a nasogastric tube, if there's a bowel obstruction, just to decompress the stomach.
And amidst all that rush, we absolutely cannot forget consent.
Ah, yes. Critical.
It's an incredibly important discussion, not just with the patient if they're able, but often with their family too. You have to be clear, you have to be honest about the risks.
Like what specifically?
Well, things like potential leaks, less common from the stump itself, but still possible stoma complications down the line like necrosis or retraction, and of course the risk of infection is always there.
Setting expectations is key.
Absolutely. Setting clear, honest expectations up front is paramount. It builds trust, helps them understand the journey they're starting. It's more than just a legal checkbox. It's foundational for their whole recovery.
Right. So with all that careful prep done, it's time to get the patient physically ready for the OR. Let's talk positioning. The standard is supine, flat on their back, arms out to the side.
Arms abducted, yeah.
But if a stapled rectal closure is planned, you might see a modified lithotomy position used instead. What's the specific advantage there?
Good question. The modified lithotomy just gives the surgeon much better access down to the perineum and the rectum.
Makes sense.
Which is critical if you're planning on using that stapler technique for the rectal stump closure.
Got it. And here's a crucial detail for surgeons. Ensuring there's adequate exposure for possibly marking the stoma site beforehand.
Oh, that stoma site marking, we really can't overstate how important that is. Doing it preoperatively, ideally with the patient awake if possible, helps make sure the stoma ends up in the best possible spot.
Why is that so critical?
Well, it's not just about long-term comfort, though that's huge. It's vital for preventing immediate issues like the bag leaking or making it really difficult for the patient or their caregiver to manage the stoma.
Oh.
A badly placed stoma can lead to major quality of life problems, skin breakdown. It's a small step pre-op with massive long-term implications.
Makes sense. Okay, once positioned, we move to anesthesia. Usually general anesthesia with endotracheal intubation to secure their airway.
Standard for major abdominal surgery.
And critically, plans for post-operative pain control are made early, often using an epidural for regional relief, or maybe a PCA pump patient-controlled analgesia.
Giving the patient some control, yeah.
Which empowers them to manage their own pain relief, giving them a bit of control over their recovery. Beyond that, prophylaxis is key. Antibiotics like, say, cefazolin plus metronidazole, given within 60 minutes of the incision. Why those specific ones?
They give good broad-spectrum coverage against the typical gut bacteria you'd expect to encounter. Covers both aerobic and anaerobic organisms.
Right. And finally, DVT prophylaxis, using subcutaneous heparin and compression stockings to prevent those dangerous blood clots.
Absolutely essential. Timely antibiotic prophylaxis is just fundamental in preventing surgical site infections, which can be really devastating after a procedure like this.
Prolongs recovery significantly.
Hugely. And DVT prophylaxis, though it might seem like a smaller detail in the grand scheme, plays a massive role in minimizing serious complications like a pulmonary embolism. It all connects back to overall patient safety, reducing morbidity, optimizing their whole recovery. Every little detail matters.
Okay, all the prep is done. Now we move into the main event, the surgical steps themselves. This is where absolute precision is non-negotiable. Here's where it gets really interesting.
The core of the operation.
We start with step 1, incision and abdominal entry. The standard approach for the best view is usually a midline laparotomy, right down the middle from the xiphoid process to the pubis.
Give you wide open access.
Exactly. Which is crucial when you're dealing with an emergency, maybe widespread infection, or you're not sure how far the disease has spread.
And for newer surgeons listening, that careful abdominal entry is so important, especially if it's a reoperation where you might encounter adhesions from previous surgeries.
Church issue, yeah.
You really want to avoid accidentally injuring the bowel underneath. Once you're inside, that initial look around the peritoneal cavity is critical. You're checking for fecal contamination, the extent of any perforation, how far a tumor might have spread.
Like a quick survey.
Exactly. It's like the surgeon's initial reconnaissance. It guides everything that comes next, and sometimes it can even change your whole operative plan right then and there.
Okay, so after that initial look, step 2 is exploration and mobilization of the affected colon. First task. Clearly identify the problem. Is it that perforated diverticulitis, a tumor, trauma?
Nail down the pathology.
Once you've got that, then comes the real work of mobilizing the sigmoid, or descending colon. This means incising the white line of Tolt laterally.
Releasing its attachments.
And as you reflect the colon medially towards the midline, This is where you have to be incredibly careful. You must preserve the ureter and the gonadal vessels lying just behind it.
Critical structures back there.
And if you need more length for the colostomy, which often happens, you might need to take down the splenic flexure, too carefully dividing the attachments near the spleen.
That meticulous preservation of structures like the ureter, you just can't emphasize it enough.
A major pitfall otherwise.
Oh, absolutely. Injuring the ureter during mobilization is a serious complication. It can lead to kidney problems, long hospital stays, more surgeries. It's a common pitfall if you're not laser-focused on identifying and protecting those structures.
How do you do that reliably?
Experienced surgeons will often gently feel for the ureter. It feels like a firm cord before they divide any tissue nearby. It really highlights why knowing your anatomy, including variations, is so crucial, especially under pressure.
Right. Okay, after mobilization comes step 3, ligation of blood supply. Here, the surgeon finds and ties off the inferior mesenteric artery, the IMA, usually near its origin from the aorta.
Controlling the main inflow.
The goal is often to try and preserve the marginal artery if possible to keep that collateral blood flow going. The inferior mesenteric vein, the IMV, is also divided, usually near the duodenum. Seems straightforward, but what's the key thinking behind where you ligate?
The critical point here is ensuring really good blood flow perfusion to the proximal colon. That piece of bowel is going to become the stoma.
Needs a good blood supply.
Absolutely. If its blood supply isn't robust, you risk stoma ischemia where the tissue doesn't get enough oxygen, and even necrosis where it dies. It's not just about the big vessels. Sometimes it's subtle twists or too much tension on the mesentery, that fatty tissue holding the vessels.
Small things can compromise it.
Exactly. A good surgeon is constantly assessing, is this bowel pink? Does it look healthy? Is there a pulse in the mesentery? Because if it looks iffy now, it won't be viable later. Ensuring that excellent blood supply is foundational for the stoma's health and the patient's recovery.
That naturally leads us to step 4, resection of the affected segment. This is where the disease part finally comes out.
The main event, in a way.
The surgeon carefully defines the resection margins, making sure they're cutting into healthy bowel on both sides. For things like diverticulitis or cancer, this usually means taking out the whole sigmoid colon and often part of the upper rectum.
Getting it all out.
And the tool typically used to cut across both the proximal colon and future stoma end and the distal rectum is a linear stapler. Why is that the go-to tool here?
Well, the linear stapler is often preferred for its speed and its ability to create a really consistent, secure cut with good hemostasis. It stops bleeding well.
Important in emergencies.
Definitely. In an emergency where time and blood loss are critical, using a stapler can save significant operative time compared to hand sewing everything. And it gives you a reliable, strong closure of those bowel ends, which is especially important for the rectal stump you're leaving behind.
Makes sense. Okay, next up, step 5, creation of the end colostomy. This is where the patient's long-term management really starts to take shape.
A life-changing step for the patient.
The stoma site is chosen carefully, hopefully marked beforehand, usually in the left lower quadrant. The process involves cutting out a circle of skin and fascia, maybe 2 to 3 centimeters wide.
Creating the opening.
Then the proximal end of the colon is gently brought out through this hole in the abdominal wall. And this is crucial in making absolutely sure there's no tension or twisting on the bowel or its mesentery.
No tension, no twisting. Absolutely key.
Finally, the stoma is matured as a Brook colostomy. This means it's everted, kind of like rolling a sock cuff down. And the inner lining, the mucosa, is stitched directly to the skin with absorbable sutures, maybe 3 size. Why is the Brook technique the standard? And why is avoiding tension so vital?
The Brook version is preferred because having the mucosa stick out slightly helps protect the surrounding skin from the irritating bowel contents. It also makes it much easier for the patient to attach and manage their stoma bag, their appliance.
Right, real benefits.
Huge practical benefits. And avoiding tension or twisting, absolutely crucial to prevent stoma necrosis. Even a small twist can kink off that fragile blood supply, leading to tissue death. A necrotic stoma is a terrible complication, often needs more surgery, really impacts the patient's ability to manage things. It's key for the stoma's viability and the patient's long-term quality of life.
Got it. So with a colostomy made, we turn to step 6, management of the rectal stump. A couple of options for closing that remaining end down in the pelvis.
Yep, stapled or sewn.
It can be a stapled closure, often using a double staple technique with a TA stapler. Or it can be an oversewn closure done by hand with interrupted stitches, maybe 2-0 PDS suture.
Depends on the situation.
And if there was a lot of contamination during the surgery, a closed suction drain might be placed down near the rectal stump just in case. What guides the choice between staples or sewing, and when is that drain really needed?
The choice often comes down to surgeon preference, honestly, but also the quality of the tissue. Is it really inflamed and thick, or is it healthy? And the patient's anatomy in the pelvis matters too.
Access issues.
Sometimes, yeah. A stapler is quick and consistent. Hand sewing allows maybe a bit more precise handling of fragile or inflamed tissue. As for the drain, that's a judgment call. It becomes necessary if there's a high risk of fluid collecting or an abscess forming near that stump.
Like if there was pus.
Exactly. If there was significant pus or fecal contamination down in the pelvis during the operation, putting in a drain helps get that fluid out, preventing a potentially nasty pelvic abscess later on, which can make recovery really difficult.
Okay, finally, step 7, irrigation and closure. The abdominal cavity gets a really good washout with copious warm saline. This isn't just cleaning, right? It's specifically to lower the bacterial count.
Especially if it's a dirty case. Wash out the bugs.
Then, meticulous hemostasis, making absolutely sure all bleeding is stopped. The fascia, that strong layer under the skin, is closed up, usually with a running strong suture like #1PDS.
Bringing the strength layer together.
And for the skin, staples or sutures usually. But it's worth noting, the skin might actually be left open deliberately if there was heavy contamination. Why would you do that?
Right. The importance of that thorough irrigation, especially with warm saline, in preventing surgical site infections really can't be overstated in these contaminated cases. You're literally washing out bacteria. And careful hemostasis avoids hematomas, which can get infected or even need reoperation.
Leaving the skin open.
That's a technique called delayed primary closure. If the wound is really dirty, closing the skin right away can trap bacteria inside, leading to a bad infection. By leaving it open, maybe packing it lightly, you allow it to drain, reduce the bacteria, and then you can close it safely a few days later when the infection risk is much lower. These final steps are just as vital as the first cut.
So what does this all mean for the patient once they leave the OR? We shift focus now to beyond the operating room, post-operative care. A huge part of this is monitoring for complications.
Vigilance is key.
Right. While a leak from the rectal stump closure is rare, a blowout where it actually ruptures is still possible. Pelvic abscesses are a concern too, especially after contamination, and might need CT-guided drainage.
Finding and draining those collections.
And of course, various stoma complications can pop up. Necrosis, like we talked about, retraction where it pulls back in, or stenosis where it narrows down. How vital is watching closely in this phase?
Oh, post-operative vigilance is absolutely critical. Many complications, like a pelvic abscess, might not show up right away, but develop over the first few days or even a week.
Takes time sometimes.
It does, and that's where the vital role of stoma education really comes in. Getting an enterostomal therapist involved for proper pouching teaching is non-negotiable.
Not just how to change the bag.
No, it's so much more. It's about empowering the patient to adapt to life with the stoma, preventing skin breakdown around it, ensuring good hygiene. It massively impacts their long-term care and self-sufficiency. It's a key part of holistic recovery, preventing readmissions, and dramatically improving their quality of life. Without good education and support, patients can feel really lost and overwhelmed.
Absolutely. And for many patients, hopefully, Hartmann's isn't the end of the road surgically. There's often the possibility of reversing it, a Hartmann's reversal.
Connecting things back up.
Exactly. Typically considered maybe 3 to 6 months later, assuming the patient recovers well and their underlying condition allows it. Why that particular time frame, 3 to 6 months?
That window, 3 to 6 months, is generally preferred because it gives enough time for all the acute inflammation and infection from the initial emergency surgery to completely settle down.
Let things cool off.
Right. And it also gives the patient time to physically recover, get their strength back, improve their nutrition. Trying to do a reversal too early when tissues might still be fragile or inflamed leads to higher complication rates. It's a balance. Let them recover fully, but don't wait unnecessarily long either.
Makes sense. Now, even with a clear guide like this, surgery always has potential pitfalls. So let's talk about navigating the challenges. Common pitfalls and some crucial tips for new surgeons from our sources.
Yes, and reinforcing why these are problems helps solidify how to avoid them. First, that ureteral injury we mentioned. always, always identify the ureters before you ligate the IMA.
See it before you cut near it.
Absolutely. In the heat of the moment, maybe there's bleeding or inflammation. It's easy to get disoriented, but blindly clamping or ligating can damage a kidney or cause a ureteral stricture down the road. A practical tip: gently feel for it. It rolls like a firm string under your finger.
Good tip. What else?
Second, stoma ischemia. You must ensure that blood supply to the colon end is good before you finish making the stoma. If the bowel looks dusky or bluish, stop. Don't proceed.
What do you do then?
You might need to mobilize more colon to relieve tension, check for twists in the mesentery, or even reconsider the stoma site. It's far better to spend extra time ensuring viability than to end up with a dead stoma.
Okay, third.
Third, rectal stump dehiscence or breakdown. If you can, reinforce the staple line or sewn closure, maybe by bringing down a piece of omentum, that fatty apron in the abdomen, and tacking it over the stump.
Like an extra layer?
Exactly. It provides an extra layer of protection and brings in more blood supply, reducing the risk of the stump leaking, which can cause a nasty pelvic abscess.
And finally,
inadequate resection. Make absolutely sure you remove all the diseased colon. Whether it's diverticulitis or cancer, you don't want to leave diseased tissue behind, only to cause problems later. Get clear margins.
so these pitfalls really connect back directly to those meticulous steps we talked about earlier, don't they?
They absolutely do. Attention to detail at every single stage directly impacts outcomes. These are often the points where seemingly small oversights or errors can snowball into major complications.
It's crystal clear that Hartmann's procedure is a truly life-saving operation for these acute colorectal emergencies. For any surgeon, but maybe especially those starting out, mastering these key steps, that meticulous mobilization, the precise resection, the art of stoma creation, and careful rectal stump management, it's not just important, it's absolutely essential for giving the patient the best possible chance.
And if you pull back and look at the bigger picture, it really underscores that proper patient selection, that meticulous surgical technique we've detailed, and really dedicated postoperative care. Those three things form the vital triad that optimizes outcomes for this complex, often urgent procedure. It really speaks to the comprehensive approach needed in acute surgical care.
So as we wrap up this deep dive, just consider how, in emergency surgery, that blend of deep anatomical knowledge, precise technical execution, and really rapid decision-making under intense pressure, that truly defines the art of the surgeon, doesn't it?
It really does.
Every single step we've walked through today, from the first cut to the last stitch and all the care that follows, is just a crucial testament to their skill, their training, and their judgment. Maybe reflect on how that kind of detailed step-by-step mastery transforms these incredibly life-threatening situations into pathways toward not just survival, but hopefully meaningful recovery for patients. It's really quite profound when you think about it, that dance between science and humanity right there in the operating room.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.